Hi everyone, I'm Hadley, and I'll be performing a musculoskeletal and neurological exam on my patient today. First thing I would do is provide privacy, perform hand hygiene, verify name and date of birth that I have the right patient, and I'd probably get some cotton to use for the sensation test. So we'll start with the upper extremities and move to the lower. Then I'll go to the musculoskeletal portion and then move to the neurologic. So I would start with inspection. I'd go ahead and I'm just going to start on the hands and then move upward. So I would start by inspecting the hands, just making sure that all 5 fingers are present, make sure that he has fingernails, that his skin is pink, making sure that he has cap refill. After that, I would move on to the palpation. So I would look at each knuckle, I'd palpate each knuckle, making sure that there's no tenderness, swelling, redness, or nodules. Just checking for any sign of osteoarthritis or rheumatoid arthritis, and he has none. After I palpate the hands, I would go ahead and palpate the pulses. So I'm going to palpate the radial and brachial. So I would palpate both radial pulses and compare sides, making sure that it's 2 plus normal, making sure that it's not weak or thready or bounding. Then I would palpate the brachial pulse, and I would palpate both sides, comparing each side, making sure that it's 2 plus normal as well. After I palpate the pulses, I would go ahead and do range of motion of the hands. So I'd have him just flex his wrist downward and then extend his hands upward. Then I would have him do the same thing with his fingers. Flex downward, extend upward. The next thing I'd have him do is place the palms of his hands flat on the table and then turn his elbows inward and outward, checking for ulnar and radial deviation. After that, I would have him make a fist with his hands and then spread the fingers apart. Good. And then the last thing I would do for range of motion in the hands is to have him touch each finger to the thumb and do it in both hands, making sure that they are equal bilaterally. And they are. After the hands, I'd go ahead and move on to the arms. So I would start with inspection. I would look at the arms, making sure that the muscle tone is equal bilaterally, making sure that hair distribution is even, making sure that the skin is even. Then I would move on to palpation. So holding the arm at kind of a 70-degree angle, just palpate the elbow down here, checking for any synovial thickening, swelling, nodules, tenderness. Then I would have him bend and straighten his elbow, checking for range of motion. And then I would have him do that against some resistance, just to check for muscle strength. Good. The next thing I would do is have him place his hand on the table and turn it backward and forward. And this is checking for pronation and supination. And that looks good. So after range of motion of the arm and checking the resistance, I would move on to the shoulders. So I would start with inspection, making sure that the shoulders are equal bilaterally, one's not higher than the other, making sure that there's no deformities, no redness, no swelling, no lesions. After I inspect, I would move on to palpation. So I would palpate the shoulders, just again checking for any swelling, redness, any pain or tenderness with palpation. Then I'm ready to move on to range of motion. So you can stand up for this one if you'd like. I would just have you extend the arm all the way up, and then extend it all the way back. Then I would check for internal and external rotation by having you place your hand behind your head, and then placing it behind you, and that's checking for internal and external rotation. Then I would check for abduction and adduction. Abduction is when your arm comes out to the side, and adduction is when your arm comes back across your body. And then I would just check for all these against resistance. So go ahead and try to, okay, good job, and come back this way. That looks good. And then I would check arm going up, okay, and then back down against resistance. Good job. And I would check this on both sides. For the purpose of the video, I'm just going to do one, and I'm just making sure that it's equal bilaterally. So now I'm done with the upper extremity portion. I would move to the lower extremities. So just like the upper extremity exam, I would start with inspection. I would look at both legs, making sure that they are symmetrical, making sure that the skin is equal in color, equal in hair distribution, looking for the presence of any varicose veins. After I inspect the legs, I would move on to palpation. So I'm going to go ahead and palpate the popliteal pulse, the dorsal pedis, and the posterior tibial. So for the popliteal pulse, I'll just have you relax your knee. I'm going to reach under here with both hands. And you're just making sure that the pulses are equal bilaterally, making sure that they're 2 plus normal, and they are. The next thing I would do, I would move on to the posterior tibial, making sure that they're equal bilaterally, 2 plus normal, and then moving on to the dorsalis pedis, and they are equal bilaterally. While I'm down here, I would check cap-refel, and it is less than 3. After palpating the pulses, I would also palpate each knuckle of the toes, making sure that there's no swelling, redness, deformity, making sure that there's no tenderness. After palpation, I would move on to range of motion and muscle strength. So I'm going to go ahead and start with range of motion and muscle strength of the hips. So normally I would have my patient laying down on a bed or something, but I'm going to have him demonstrate it standing up so you can get a visual. So for the hips, I'll have you extend your leg with the knee straightened, and then send it behind you. And then I would have you bend the knee, and set it back down. And I would have him do this on both hips, but for the purpose of this video, we'll just do one. Then I would have you bend your knee and check the internal and external rotation of the hip. They're intact. Then I would have you practice abduction and adduction. So abduction, send the leg out to the side, and adduction, bring the leg across the body. Very good. So then I would test the strength of the hip against my hands, adding resistance. So I would have you flex the knee, try to flex the knee against me, like bend the knee, there you go, and then that's good. And then I would have you do that on each side, and making sure that the strength is equal bilaterally. So after I took range of motion of the hips, I would go ahead and move on to the knees. So I would have him flex and extend the knees. Very good. And then I would have him flex his knees while I push down to test the muscle strength. After I test the muscle strength of the knee, I would move on to the ankles. So you can go ahead and sit down for this portion. So range of motion for the ankles, I would just have you point your feet towards the floor and then flex them back towards you. Then I would have you turn the soles of the feet inward and then outward. Then I would test the muscle strength of the feet by having you flex against my hands and then push against my hands. Very good, thank you. So after I've done range of motion of the ankles and feet, I can move on to the musculoskeletal portion of the exam. So again, I would start with observation. Just looking at size, contour of every joint, which I've already kind of assessed and discussed. I would look at the skin, making sure that it is equal bilaterally, making sure that there's no cool extremities, making sure that the pulses are everywhere. I would check for masses, deformities, swelling. After observation of the joints of the deep knee bends, then I would move on to check the spine for scoliosis. So I'll have you stand up. And so with the spine, you're just checking for the normal S-curve, making sure that there's no scoliosis or kyphosis, which is kind of a hunchback. You can look at the spine this way, and then you can also look at the hips and see if one is maybe higher than the other. And that can indicate scoliosis, or if one scapula is higher than the other too. After you assess the spine, you can kind of palpate each vertebra all the way down. So after inspection and palpation, we can check range of motion. So I'll have him bend over and touch his toes. Okay. And then I'll have him bend side to side. Very good. And then I'll have you twist your shoulders side to side. And then bend backward. Very good. Okay. So after I assess the spine for scoliosis or kyphosis, I can assess gait. So I'll just ask him to walk 10 to 20 feet, watching the gait, making sure that it's smooth, rhythmic, and effortless, and it is. After I assess the gait, I can do Romberg's test. So I ask him to stand with his feet together, palms up in front of him, keeping his eyes open at first, and just assessing for any swaying. After he does well with this, no swaying, you can ask them to close their eyes, and once they close their eyes, you can assess for swaying again. And he has no swaying and no loss of balance. After the Romberg test, I can move on to my neurological part of the exam. So I'll have you take a seat. So for the neurological part, I would assess level of consciousness, making sure that he's alert and oriented. Then I would assess the Babinski's reflex. So this is when you stroke the lateral edge of the foot. And a positive Babinski's would be a fanning of the toes outward. This usually disappears by 24 months. And so it should be positive in babies, and then in adults it should not be positive. So I'm going to go ahead and check and it's negative. So after the Babinski's reflex, I'm going to check for coordination of skills. So I'm going to start with a rapid movement test. So I'm going to ask him to pat his hands on his knees, lift them up, turn them over. So I ask him to do that, and then I ask him to speed up. So what I'm looking for this is making sure that they're equal, quick, rhythmic, and they are. So after this test, I can move on to the finger-nose test. So I'll ask him to extend his hands, close his eyes, and with his index finger, alternate touching his nose. And then I'll ask him to speed it up, making sure that it's accurate and smooth. And it is, so thank you. The next thing I'll have him do is the heel to shin test. So normally your patient will be laying in a bed, but you'd have one leg extended, and then you may need to help them put their opposite heel onto their leg, and then you just ask them to slide it down and back up. And this is checking for coordination. So I'll have you extend this leg, and then I'll have you place that on your knee, slide it down and back up, okay? And then I'll have you do the other one as well. And this is to make sure that the heel moves in a straight line, to make sure that there's no ataxia and that he's coordinated, and he is. The next thing I'm going to do is the position sense of the finger test. So I would just hold the finger, and I would go through each finger and move it in the various range of motion to make sure that it can move in each. So for the purpose of this video, I'm not going to do every finger, but they are intact. After that, I'm going to move on to sensation. So I'm going to use this Q-tip, and the end is cotton, and I'm going to touch various places on his body with it with his eyes closed, and whenever he feels it, he could say now. And this is testing for sensation, because if he doesn't say now, then we know that sensation is not intact on whatever side. So go ahead and close your eyes and say now whenever you feel.
No. 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 No.
Very good. So I can see the sensation is intact bilaterally. The last thing I'm going to do is check for the deep tendon reflexes. So I'll have you go ahead and sit on the table for this portion. Normally I would have a tool to help me elect the deep tendon reflexes, but I'm just going to use the end of my hand. So the first one I'm going to start off with is the brachioradialis. So I'm going to get him by the thumb here, and then I'm going to strike the forearm 2 to 3 centimeters above the radial styloid process. And what I'm looking for here is flexion and supination, and it's present. After this, I move on to the patellar reflex. What I'm looking for here is just an outward kicking of the foot. I'm going to strike just below the kneecap. Okay. And then after this, I'm going to move on to the Achilles, striking behind, just on the Achilles tendon, looking for an upward flexion of the foot. And that is intact. And that concludes this exam.